Hello, everyone, and thank you so much for joining us for this webinar that's sponsored by the Lucille Packard Foundation for Children's Health, entitled Paid Family Caregiving for Children with Medical Complexity and Disabilities. This webinar is one of the quote-unquote products arising out of a project that was funded by Lucille Packard Foundation for Children's Health over the last couple years that was entitled Advancing a Family-Centered Evidence-Based Policy Agenda for Pediatric Home Health Care. I don't think I need to tell anyone because there are a lot of people here, and pretty much everyone who's here knows, as our advertisement said, that pediatric home health care is in crisis. And you know, the crisis is one of workforce, the crisis is of the ability of our children to live at home and in their communities and be with their families. But what we're here to talk about, you know, there's many moving parts, and particularly today, as we are coming out of a pandemic and facing the looming unwinding of the public health emergency, and now we're beginning to hear discussions of possible Medicaid cuts, but the obligation to provide medically necessary home health care for children with medical complexity and disabilities through Medicaid remains. So if we don't have shifts filled and we still have need and kids and families still want to be at home, what do? As family members, parents, legal guardians, what do? We provide the care, and unfortunately in most states that care is unpaid. So that's what we're here to talk about. Can families of children under 18 be paid to provide care? Yes. Next slide, please. My name is Kara Coleman, and I'm a policy consultant with Family Voices and also with Bluebird Consulting. And I've been the co-principal investigator of the Lucille Packard funded project that I mentioned earlier. Next slide, please. My co-PI is the wonderful Dr. Carolyn Foster, who is a pediatrician at Lurie Children's in Chicago. Carolyn is many things. She's a primary care provider, a complex care provider, but she is supremely dedicated to researching and advancing home health care for children and their families, and particularly through family partnered research. Next slide, please. Our two speakers joining us today, first, Bill Sapansky, who has over a decade of legislative experience in home health care in particular, but has also worked overall for the last 20 years in the home care industry in general. Bill brings a lot of personal and professional experience to the work that he does with presidents, CEOs, families, providers, legislators, everyone working together to create change in home health care. And our next speaker, Nanette Salasic, comes to us from Arizona, Raising Special Kids, which is the family-to-family health information center in Arizona, where she is the healthcare systems administrator and has worked in that role for 14 years with Raising Special Kids. Most importantly, Nanette has 6 children, one of whom, Annie, has spina bifida and has used home health care. Next slide, please. We'll move into the housekeeping and then get down to the goods. There is live captioning available. You can select the CC closed captioning in Zoom or click the link in the chat to view captions. Next slide, please. Ask questions. Too many people, not enough time, can't raise hand and open it up, but there is a Q&A box you'll see at the bottom of your Zoom. That's where we want your questions. Submit them there and we will get to them. Next slide, please. Last bit of home housekeeping. Golly, I'm trying to go so fast to get to the meat, I'm already messing everything up. Anyway, all of this, including my flubs, are going to be recorded, so you get to listen to them again. The recording will be shared and all the slides. As I said, questions and answers, put those in the Q&A box. We only have an hour to really start a conversation. That's how we view it, a national conversation starting, bringing all kinds of states together to begin to share what are the levers and the policy options that do exist for us. So we will try our best to get to all the questions and answers, but want to let you know that we will stay past the hour to try to answer some of them live in a recording, but also we'll be answering some in writing. And we're going to do our best to minimize jargon, including the use of acronyms. So now I will hand it off to my dear friend and co-PI, the good Dr. Carolyn Foster. Take it away.
Thanks, Kara. I hope everyone can sense from Kara's voice and my own the excitement that we have of all of you joining us today. I'm amazed already by how many of you have joined. We wanted to start out with some simple leveling of the conversation. We know people are coming from all over the country, might have different backgrounds. So let me just do a little bit of an overview to make sure we're all talking about the same terms. So pediatric home health care are the services and supplies delivered in the community setting for individuals with chronic conditions and disabilities to support independent living. Today, we're going to focus on services specifically, which can range from help from activities of daily living to more extensive clinical tasks. And we have a list there to give you a sense of the sorts of professions that might be involved in home care, right? It ranges from personal care to home health care aides. We'll refer to certified nursing assistants a few times, sometimes called CNAs throughout this. And I think what people think of most often is visiting nursing, or especially shift nursing, right? Someone who comes day and night, often called private duty nursing, to provide services for a child. Next slide. We wanted to make sure everyone who's participating in this conversation is aware of at least two of the major laws that are relevant for pediatric home health care. The first is the Medicaid Act from 1967, which has provisions called Early and Periodic Screening, Diagnosis, and Treatment. Most of us refer to it as EPSDT. That ensures that those persons under 21 with Medicaid have entitlement to medically necessary services under the T part, the treatment. And that specifically includes home health care services. What this means is that children who have Medicaid have the states have an obligation to provide and help arrange, right? Not just provide it, but make sure they have the coordination to get the services with reasonable promptness. This is important because this is regardless of whatever is the coverage for adults in that state. EPSDT is unique to children. The second major law is the American for Disabilities Act, which was reinforced with the Olmstead Supreme Court case in 1999, which really has what we call the integration mandate. It says that states are required to provide programs and activities and services that ensure that disabled persons, including children, have the option to receive care in the home rather than in an institutionalized setting. So we should just have these laws in the background as we have this conversation to understand how this impacts our policy decision-making within each state. Next slide, please. So as Kara alluded to, I think it's fairly broadly known that there are many challenges within pediatric home care. They vary. Certainly, we know there's wide variation, both in public and privately insured plans for how much home health care is actually covered. But even if it is covered, we know there are insufficient hours that families actually receive, right? So even if you're eligible for 12 hours a day, you may not actually be getting those. And there's been well-documented information indicating that for patients, this leads to unnecessary hospitalizations and even institutionalization. And beyond what patients themselves, the children experience, we know that there leads to many impacts on families, including the financial costs borne to families who have to replace those services with their own medical labor. And there's been some research documenting this. We'll have some of these references available for you at the end. We did some work publishing that it can be tens of thousands of dollars of lost income for individual families. And really it adds up to billions of dollars of lost wages in the economy. So it's not just that individual families are affected, but economies of the state are impacted as well when families drop out of the workforce. Next slide. So really what we're here to talk about today is one policy option, which is called paid family caregiving, to meet the patient's medical needs and also improve or try to enhance or provide options that might also meet families' needs and improve families' financial well-being. Some states have had longstanding programs, but they've typically been limited. For example, they may not allow parent guardians to be the person who provides care. It has to be another relative, or it requires the family to be licensed as an RN or LPN. We do have some emerging data from the Colorado CNA program that shows increased retention and equivalent care. So we have a gathering information about that. And I think as Kara alluded to, with the public health emergency, there was a wide flexibility in programs that happened over COVID. And so this is a very exciting time, but also a nerve-wracking time for a lot of people because important programs that were made flexible may be going away. And so we'll see there's a lot of active legislation in states now. We also will have links to that at the end that shows that varied roles and scopes are being explored in different states. And really, we're hoping today to have some conversations about what are the opportunities to expand such programs that might work for patients and families. So we're going to start with the first perspective from Bill, who's going to share his experience and perspective as someone who works within the home healthcare industry and the government affairs. And it's really exciting, again, to see all of you here. Bill, do you want to go ahead?
Yes, I just had to take myself off mute, so I apologize, everybody. Good morning, good afternoon. My name is Bill Stefanski, and I will be speaking about the Family Certified Nursing Assistant Program or Family CNA program today. There are many names states can call aides that work in the home, so please keep that in mind as we go through this presentation. We will briefly touch on those later in this presentation. These slides, along with other handouts, will be available after this webinar for your review. For the sake of time, some of the slides I will touch on briefly to leave time for other slides to cover in more detail during this presentation. I will review in this presentation what is private duty nursing and what issues are we trying to solve. How does the family CNA model work? How does this model work in some states currently? And what steps to discover how it can work in your state. Next slide, please. Private duty nursing, or PDN, is hourly skilled care provided by a nurse, a registered nurse, a licensed practical nurse, or if you're in the state of Texas, a licensed vocational nurse or LVN. It is mostly reimbursed by Medicaid. Most clients are children under the age of 21 years old, but some adults do receive the service. Services are deemed medically necessary by a doctor and based off of the skill need, not diagnosis. Most children who have PDN have at least, if not all, the following skill needs: a feeding tube, trach, or ventilator dependent. Because of the nursing shortage and low reimbursement rates, cases are very difficult, if not impossible, to staff after COVID. Before COVID, nurses generally can make $10 to $20 more an hour working in a hospital than working with a private duty nursing agency. Now it's double to triple a nurse can make in a hospital compared to a PDN agency or private duty nursing agency. With the lack of staffing, this caused numerous delays in discharging from the hospital, which can last months, if not years. Lack of staffing causes parents to lose their jobs in order to stay at home to care for their children as caregivers. Next slide, please. The Family CNA program helps to resolve some of the issues by utilizing family members, including parents and guardians, as CNAs. It started in Colorado over 20 years ago and in New Hampshire over 15 years ago. Children already qualified for a PDN who have lower acuity needs such as feeding tube or a trach that has mild to moderate needs may qualify for this program. Children who have more severe trach needs than those on a ventilator will not qualify for this model. These clients will need a nurse for their care. Nurses who currently working with lower acuity cases could be transferred to work with these higher acuity cases to staff these cases fully. Parents or family members of lower acuity client would go through the family CNA training that is paid for by the agency with no strings attached to the family. Once completed and approved by the Board of Nursing or Department of Health, then this individual could be hired by an agency. This aide would have to go through all the same background checks and training requirements of any other employee of that agency. Using nurse delegation of skill tasks like tube feedings and even trach care can be delegated to the CNA by an RN while they're on the clock as a paid caregiver with this agency. One point I'd like to make is that this model is sometimes confused with the consumer-directed model, but it's different. The family CNA model is based on medical need and overseen by an RN employed by a home care agency for nursing delegation to occur. Please note this model is not Medicaid expansion or trying to expand the private duty nursing benefit beyond those who are medically qualified for the private duty benefit in that state. By allowing the parent mom to pick the caregivers she wants to care for her child, she will get the hours filled by the people she knows and trusts. By parents and family members becoming CNAs, we are not only teaching them skills, but why we do what we do. They become informed consumers, or as my parents in Colorado say, I know when to freak out and not to freak out. By providing consistent care, the need for hospitalizations go down, drastically saving the state a lot of money on affordable hospitalization. Next slide, please. So as we discussed, these are some benefits of the model. I'll just let everybody quickly review that. And then next slide, please. This slide shows the background checks and training each employee goes through when hiring on it with a home care agency. The second chart shows the assessment process for a client that an agency performs with this model in Colorado. Next slide, please. The orange line shows the hospitalization rates for clients receiving regular private duty nursing in our PDN offices for the last 2 years. So yes, you can see anywhere from 8 to 12%. This includes all hospitalizations, not just rehospitalizations. The line in blue shows parent CNA model hospitalization rates over 2 years in our 5 Colorado offices that serve currently about 800 clients. Next slide, please. This slide is comparing 2 different state models in Pennsylvania and Arizona. One thing to remember is every state model will be different since every state's Medicaid benefit can be administered differently by each state. Both of these states are based off a home health or visit benefit, not an hourly benefit. Pennsylvania does not allow for skill delegation of tasks, but Arizona does and allows for feeding tube and trach delegation. PA allows Pennsylvania allows for anyone to become a caregiver, but Arizona allows for family members only to participate in this model. In Pennsylvania, the model was there was concern in the last few months that this model would not continue after the PHE or public health emergency was over. Pennsylvania Medicaid viewed this model as providing personal care services, even though they were being provided by a home health and a non-PCA. Personal care services are not allowed under CMS rule to be provided by a paid family member. Recently, PA Medicaid announced it will continue this model after the PHE is over in May. CMS helped to clarify the interpretation of this model is allowed under a home health benefit for Pennsylvania Medicaid participants, even after the PHE is over. In Arizona, training is created by each agency and approved by the Board of Nursing. It's not standardized, so if the family switches agency, the agency will need to retrain that family caregiver, as each agency does not know specifics what the other agency train over with that family aid. Please keep in mind that the Colorado model started out with one mother who was a CNA who appealed the decision from Colorado Medicaid not allowing her to be a paid caregiver. After Medicaid allowed the mother of the client to be a paid caregiver for her child, the model slowly grew in Colorado. Your states may not start out where you intend or want your model to be at first, but it can evolve in regard to delegation or who is allowed to be an aide as the model gets going in your state. Next slide, please. This slide again shows what we call an aide in a particular state. They all have different names, but it's all potato. Next slide, please. This model is currently active in 3 states, Arizona, Colorado, New Hampshire, Poland. Partially in 3 states, Pennsylvania, Indiana, and California, because they do not allow for delegation of skill tasks. The other states are considering adding this model to legislation or starting a model. Montana and Connecticut just announced legislation to add this model in their state if it makes it through the legislative process this session, and there's many other states that are working on legislation currently. Next slide, please. The next slides, I'll discuss how to figure out where this model can fit in your benefit. I will discuss in some instances, in some instances that you may need to get legislation created to add this model in your state. For an individual, this may be costly and very lengthy in process, sometimes taking years. I suggest forming a coalition or working with associations like the home care associations, partnering with home care companies like Team Select, or in order to achieve this model added in your states. Next slide, please. Okay, so the next 4 slides, we're just going to kind of talk about where this model will fit, and I will just go over this briefly, but this is kind of where we look to see where this model does fit. And again, as Dr. Foster just mentioned, these are all available after this webinar as well. So you have to look to see under private duty nursing, is this a state plan? So there's a state plan and waiver. A state plan is very important because CMS has legal opinion, only a legal opinion, it's not written, that says only an RN or LPN can provide this service. So if your state is a state plan, it has to go under a home health benefit and not a state plan. Also, you want to look to see if there's any prohibition, any regulation that keeps a parent from being a paid caregiver that's put in by Medicaid or the legislature as well. If no, then it talks about the waiver, your next steps with the waiver. Next slide, please. Is there a prohibition that allows, does not allow parents or family members to do this under home health benefits? If yes, there need to be legislative changes like we're doing right now in Texas and in Florida where there's clear prohibitions. If no, again, you would want to check these different things to look and to speak with Medicaid to see if you need, if you can go ahead and do this benefit, or do you need legislative approval to do so. Some Medicaid systems would like legislative approval, even though they do have the power to do it on their own. So it just depends on that states and what they would like. Please note that CHAP, ACHG, or the Joint Commission, these are accreditations that home care agencies are usually accredited with, have no barrier in regards to this model, and they allow it as long as the state allows it in their state. Next slide, please. You'll also want to check with the Board of Nursing in regards to delegation of skilled tasks. And again, it takes you through the steps there. And then the next slide. I'm sorry, next slide, please. Okay. Then the next is talking about can and they be delegated those tasks. So, and again, it just takes you through the steps as well for those different things. That's actually all my presentation for now. And I will turn it back over to Kara. Thank you.
Thanks so much, Bill. I want everyone to relax for 1 second because that was a mountain of information and most of it probably didn't get processed. So I just want to be clear again that you will get the slides and you will get the recording. But thanks, Bill, for sharing so much. I mean, this is, as we all know, this is such a complicated issue. And there are mountains and roadblocks in language, in acronyms, in so much of this in the layers. And I thought you did a really great job even early on, Bill, in sort of breaking out that specific model, family CNA, and saying, this is different than the consumer-driven waiver, which, you know, this is the challenge with Medicaid. It varies. It's a federal model and state implementation and layers and difference in language and routes and easy ways to see things not working. But I love in these last 4 slides as you created a way, like a diagram, a way for people to take this. As you noted, one family in Colorado started this, and we have 764 people on today and many, many more interested that can take it from here step by step. So with that, I would love to introduce our next very powerful family member and family leader from Arizona, Nanette Salasic, to take it away, please, and talk about the Arizona experience. Yep, thanks.
Awesome, thank you. Next slide. So thank you everybody for just giving me a few moments to share a little bit about our story. I am a licensed social worker here in the great state of Arizona, and I've been providing support to families that raising special kids, like Kara mentioned, for over 14 years. But my most important job, and I always say my PhD, is in motherhood. My husband and I have 6 amazing kiddos. I often joke that I'm not sure how that happened. I promise I know how it happens, but never ever dreamed that we would have so many kids. And we actually have several that have got some medical conditions. But the one that really introduced us into this whole world of having a child with special needs is front and center there in our family picture, our daughter, Annie. Our daughter was our 3rd child. And we went in for the typical 20-week ultrasound to find out what we were having. And it was that day that our world changed forever. We learned that day that our unborn baby had spina bifida, a diagnosis of myelomeningocele, the worst form. She also had Chiari malformation of the hindbrain, which I didn't understand what any of this meant back then, but knew that it was very scary. I'll never forget, after receiving the diagnosis, like any parent, and I know there's many of you on this call today that are parents yourselves, you kind of just go into shock. And I remember going home from that appointment and having to mourn the loss of the perfectly healthy baby that I was expecting, with somehow having to wrap my brain around this new precious child, again, not having any clue what the diagnosis meant. So long story short, my husband decided to do research, and he's the one that found the doctors that had pioneered in utero fetal surgery. I know it's a little early this morning, but that picture there on the corner, that's my lovely uterus with Annie inside. At 26 weeks gestation, I had in utero fetal surgery for her spina bifida repair, and that was done in Nashville at Vanderbilt Hospital. Recovered for 3 days, flew back home to Phoenix, and then I was on strict bed rest for the next 10 weeks. And then she was born here in Phoenix via C-section at 36 weeks. And, you know, there is no cure for spina bifida. So although this surgery does provide better odds for the children, it doesn't mean that the spina bifida is going to be taken away. So she has undergone countless hospitalizations for infections, life-changing surgeries, and is doing incredibly well. Annie is 19 years old and she's a sophomore in college, and she really hopes to do child life therapy at a pediatric hospital one day, which I know she can. Next slide. So like we mentioned, I work over at Raising Special Kids. We are the Parent Training and Information Center for the entire state of Arizona, and we're also the Family Voices chapter. We provide support, guidance, information to parents that have, children and young adults with special needs. Next slide. So the history of the licensed health aid service here in Arizona, that's what we call it, LHA. It really was born from a collaborative effort among state agencies like our Medicaid system, our Department of Developmental Disabilities, Department of Health, the Board of Nursing, and many other stakeholders. I'm sure many of you can agree that there is probably a statewide nursing shortage in your state. There is here in Arizona, and that truly was one of the things that motivated home health agencies like Team Select to go ahead and help get this program off the ground. Of course, COVID, the pandemic, affected our world in big ways, and one of the things that it produced was this urgency that parents and family members had when they frankly were afraid to have providers from outside the home come in to care for their child that possibly was immunocompromised. So our licensed health aid program here in Arizona is not tied to the flexibilities that come with the pandemic. So there are some programs where parents are allowed to be paid caregivers for their minor children, but those are different and are supposed to end, whereas this program is to continue. And then, like Bill mentioned, all the different home health agencies get their training modules approved. Next slide. So this is the definition, the purpose of the licensed health aid service. The program supports a path for qualified family caregivers, once licensed and trained, to be paid to provide skilled care to their minor children and improve access to care. Next slide. So who can be trained? Many people can be trained. I can tell you we get calls daily from grandparents, dads, moms, siblings. There's many folks that can go ahead and step into this role. Next slide. So in terms of the process, and Bill did cover it a little bit generally, but in Arizona, I can share with you that when we have a family, a parent, a guardian that calls us, the first thing we check is that their child, their loved one, is receiving long-term care services. So they have to be receiving, Medicaid for an individual with a disability, and also they have to be approved for those skilled nursing hours. So not everyone that receives long-term care is eligible for this service. And then of course we share with them the home health agencies that offer the LHA training. Typically it's a 2-day training. And then we confirm that that agency, that their training has been approved by the Arizona Board of Nursing. We also explain to folks the different requirements, the different paperwork that they'll be filling out. So typical things like Article 9, CPR first aid training, fingerprint clearance, and of course TB test. And then there is a fee. So there's a licensing exam fee of $50, but our agencies here cover that fee for parents and guardians that are interested in training. Next slide. So I could go on all day about the pros. You guys, there's so many things that are beneficial, but just to cover a few, this program truly improves access to quality for the child. It presents an opportunity for family members to earn a living, providing skilled care for their loved one that qualifies. And one of the biggest things is that it truly alleviates that nursing shortage. So by adding an influx of licensed health aides to the workforce, our nurses, our LPNs, they become available to care for higher acuity patients. And then of course, there's a huge cost savings here that we've noticed, with Medicaid and taxpayers. So 30 to 50% of savings for every hour of nursing care that's replaced with LHA. And then we've seen a huge reduction in the unplanned hospitalizations for medically fragile children. Next slide. So there are some restrictions here in Arizona. One of the things, like Bill mentioned, is that here in Arizona, a long-term care member has to be under the age of 21. So here in Arizona, we don't have this available for those that are 21 and older. Members receiving services are not eligible unless they have been authorized, assessed and authorized to receive private duty nursing or skilled nursing hours, which is kind of unique. And then, we here in Arizona, if we have a parent or a guardian that gets trained, they can only provide help and support to their immediate family member. I think in Colorado, you can get trained to be a CNA and then you can provide help for your neighbor, your friend, but not here in Arizona. Next slide. So when it comes to addressing concerns, there's lots, and this is probably the most popular that we hear. Out in the community, we sometimes hear, why on earth would we pay parents to care for their own children? Caring for your child is just part of being a parent. And I can tell you, when I respond to them, I respond kindly and from the heart, but I share that caring for a medically fragile child is nothing typical of a typical parenting situation. So many family members are providing nursing level care for their children, and it's just not what we see as typical parenting. It truly requires a lot more skill, a lot more time. That continuity of care really does help decrease hospitalizations and ultimately reduce the cost to the state and other insurance providers. And remember that reimbursement rate, since it's lower for a licensed health aide than an RN would receive, there's really an overall cost savings to the state, which makes a big difference. I think when we share, again, from the heart, and we explain to folks, what a difference this makes, I think we've converted a lot of people, to understand what families go through is it's a lot. And the pandemic kind of taught us a lot of new things. And I think this was one of them, probably one of the biggest ones, that, parents do need to be supported and paid for all the things that they have to do for their medically fragile children. Next slide. So that's it for me, you guys. I did share our website, phone number, if you ever want to refer, a family here in Arizona, or perhaps, sometimes we get families that are moving out of state, and we can definitely get them connected with their Family Voices chapter in another state. So thanks again. Kara, back to you.
All right. Well, there are a lot of questions coming into the Q&A, and also I see a bunch that recently have got into the chat. Remember, any questions that you want us to really answer, please try to put them into the Q&A. As you guys well know, this chat has been a little bit active, so we want to be sure that we can capture everything and respond to everything. So with that, we're going to open it up now and start working through some of these questions. I'll start with this one, maybe for Bill. It's a question from Catherine Farrow asking, what if the family caregiver actually already has an RN license? How does all of that work?
No, that's a great question. So it just depends if your state allows, in most states now, especially after COVID, most states have allowed parents who already are RNs, LPNs, or LVNs. Don't leave Texas out, LVNs. If you already are a nurse, then you can be a paid caregiver to do that. Unfortunately, a lot of parents don't have that, discipline already, but it just depends on your state. But most states do have that. You can find that information in your private duty nursing, most states have a private duty nursing manual or your private duty nursing regulations. It will address that in there.
Great. Thanks, Bill. Carolyn, did you want to add something on that one as well?
Yeah, certainly it depends on the state. But RN LPN for existing RN or LPN, that's the strongest case because it's actually already written into part of the law. So that's one of the ones that's most noticeable. One thing I wanted to make sure everyone was aware of is that depending on your particular state, you may actually not necessarily need new legislation. So I think Bill's walkthrough is really important. For example, I'm in Illinois and we are working through regulation changes right now that would actually allow parents without a license to be paid. So it can really vary from something that's quite, I don't want to say it's this straightforward, but it doesn't require legislation and it may not even require a license, all the way to new legislation with a license. So, and I think Bill made a great point earlier that building a coalition of the people in your state who are interested in seeing this change is probably one of the first steps that would be really important for this policy change to happen. One question I've seen pop up a couple different times in different ways is, and I don't know, Bill again, or Annette, or even Kara, you might be able to best answer this. What is the difference between what we're talking about, paid family caregiving models, and traditional consumer directed or person directed care models? I think that can be a little confusing. Bill, do you want to take it? I see you nodding.
Sure. Yeah, no, I can definitely take that. So the consumer directed model typically is not agency driven. And some models and agencies are involved where agencies just do the payroll and HR and things like that. But they're really not overseeing care. And it's not overseen by an RN, and it's typically not directed by a physician, which in our services are. So that is the main differences. And in order for us to do delegation of skill tasks, which I know a lot of parents would say, well, why would I need someone to delegate this? I'm already doing it off the clock. And I completely understand that. But when you are in the eyes of the law in the state and you are a CNA, you're taken out of that parent role and just considered as a CNA or an aide or a home health aide. And with that being said, you have to then delegate tasks. And so that's why it's important to have it under this model and not a consumer directed model, because on a consumer directed model, you cannot delegate those skill tasks. Now, there is states like Colorado who has a consumer directed model called IHSS, and that allows for parents to, they don't have to worry about delegation. They can do any of these skill tasks that they like because the state waived delegation. But I like to caution everybody before say, okay, great, let me do that in my state. Colorado is much more advanced in this program and in this model. So a lot of states are not going to be as comfortable doing that. So that's why I was saying in my presentation, you'll want to start off at a certain place. You kind of build it from there. And that's what Colorado did. Colorado didn't even allow for delegation of skill tasks until several years later. So you may have to start at a certain point, maybe not the point where you want, but then you build it from there.
Thanks, Bill. I don't know, Carolyn, if you think too, we're a little overwhelmed here and sorting through our I feel in all these questions and trying to group together because a lot of them all connect and touch. But I wonder, Carolyn, if you agree that the way that Bill kind of finished up that answer goes into, there's several questions having to do with, what type of oversight is given to the families, perhaps when they become CNA or licensed home health aide. And there's like one question, particularly from Massachusetts, that has, if you remember from Bill's slide, the complex care assistant program, I think, coming. And Barbara from Massachusetts was sort of asking, like, is there a way to waive or modify requirements about training and supervision and all of that kind of stuff? So I don't know if Bill, you want to answer it, and Annette, if you have some thoughts as well on how all that works. You were mentioning, Bill, the delegation of nursing duties and who's supervising, who's watching, training, all that kind of stuff.
So it really depends on the state. I will tell you that's what makes it a challenge for someone like myself to help implement this in other states, because every state is going to look at this differently. Every Medicaid system, Board of Nursing, sometimes your Department of Health. That's why I mentioned Department of Health, because sometimes aids are controlled by the Department of Health. It just depends on the state. So you have to look at those different things. I know in Massachusetts, that's one to talk about with the complex care system. Could parents go ahead and test out of it? I know that's being looked at by the state. And I know it has not been fully addressed yet, but I know that's one option that's been, been looked at and considered, not only in Massachusetts, but in other states as well. The one thing I will have to say is overall, one thing that I know is the reason why I do champion why parents and family members should go through the CNA training is, as a former administrator, I saw a lot of parents when they came home from the hospital kind of like robots. They knew what to do with the task, but they didn't know why we were doing what we were doing. And, for example, I can't tell how many times I've had conversations about wearing gloves. Yes, I would just change my child's diaper, but if your child has a compromised immune system, you would want to be wearing gloves. So things like that seems simple, but I think you kind of miss overall. And it's explaining that to the families and the parents, and no matter if they're on the clock or off the clock, they have that knowledge base. And that's why you see those hospitalizations drop as much as they do. And one thing important about this, of course, especially our stakeholders who are on this population that we're speaking about makes up typically 1% of the population in the state, but it can make up to 40%. I'll repeat that, 40% of the Medicaid spend in the state. And that's not because of nursing, that's because of hospitalizations. And so at $4,200 a day, and that's on average, it's a lot more depending on where you live in this country, that's where the cost is. And so if we're making sure our families and our parents have the resources they need, consistent care, and they're informed consumers, that'll help drive down those needless hospitalizations, which saves the states a lot of money. And then hopefully the states will then use that money for the nurses who are still working on ventilator cases and trach cases, and give them the pay raises they need.
Yeah, Bill, I love you mentioned that the gloves. So there's so many times where I'm at an appointment for our daughter, and they'll ask me, "Are you a nurse? Are you a doctor?" And I say, "No, I'm her mother, and I've learned how to care for her throughout the years." But then being trained, I get all the training, I learn the skills, and then I get the help with the equipment. So once I'm trained by the agency is providing those gloves for me, so I don't have to go out, and purchase them myself to care for her. So it really is, it's not a ton of oversight. So I don't have somebody checking on me every single day to make sure that I know what I'm doing. But once I receive that training and that licensure, I've got it, and I can go ahead and provide the care that she needs.
And typical oversight for aides in most states, it's every 14 days they come out and do a supervisory visit. Right. So that's customary in most states. And there's also the recertification, and always happens when you have a nurse or aide in your home. I did just see a comment. I wanted to address this. This is a great comment I do want to address. That someone had said that it seems like we're shifting the responsibility to the parents with this to try to staff the cases. But you have to remember too, the parents are staffing cases. I mean, and they're already doing this. What we're trying to do is give the parents a livable wage. That's the biggest thing. One, and first and foremost, give them a livable wage, give them benefits, give them 401k, things like that, for a service that they're already providing for a child. Give them extra added support. So they're going to have the same added supports that we give to any of our employees. They're going to have it teen education. They're going to have the nursing oversight, 24/7 availability, things like that. So they're going to have all those things. But it's giving parents another option. But the biggest part of this is optional. You don't have to do this. Even if your child medically qualifies for disability, it is still up to you what you would like to do for your child and how you want services carried out. So that's the biggest thing that I always say, that, especially to all my legislators, is it is up to the family. It's their choice what they want to do. Because for some families, this is not the right choice, and that's okay. But I think what's important about this model is giving you a chance to have a choice and not just trying to be fitted into one certain section.
That's such a great point, Bill, and thank you for grabbing that out of the chat. And because that was a point sort of that I wanted to make, is that I think, we've kind of danced around it, that in reality, all of this is often shifted to families, right? Paid and unpaid. We have many jokes about, oh, care coordinators, great. We each have 10 and our job is coordinate the care coordinators, and the same in home health. And I wonder if this movement towards paid family caregiving, may encourage the system to recognize families as full and equal partners of care teams in the way that they are not. It's sort of this, pink polka dotted elephant in the room. We provide all of this care often and aren't always valued and part of, care teams completely. And so not advocating that everybody should, but it's a reality. We're already providing it. And so, and if you recall in Carolyn's great slides too, the cost burden, that families have from providing this unpaid family caregiving is that often we're pulled away from our ability to work outside the home. And so, and it is cost shift anyway. Yeah. Now I'm going off back to the questions. Carolyn, I don't know if you had a way you wanted to go, but I had one. I do.
Yeah, thanks, Kara. I do want to reinforce, because I just saw a couple comments in the chat. That we shouldn't be afraid that offering this as an option means that we also don't still think we need to continue to work to expand the nursing workforce. So I think those things can be done simultaneously. We can support paid family caregiving as a policy while still saying there needs to be a robust home nursing and CNA non-family workforce, right? So those two are not mutually exclusive. And so I want to reassure people that we don't see this as a replacement of the nursing problem. It's one policy solution towards working towards the whole.
Dr. Foster,
Oh yeah, please go ahead.
I absolutely agree that the money that we're talking about saving not only can be used to help with cost of living adjustments and actual salary increases right now for those nurses that's needed, but also right now you see all this legislation being done by legislatures and meanwhile to encourage people to go into the hospital. What about home care? What about PDN? We also don't do clinical trainings in that. This is stuff that can be invested. Giving stipends right now. So if you come out of nursing school and you want to do private duty nursing, you work here for 2 years, you pay your education. This money saved could be utilized for those services to also bring more people into the industry and into this, especially this part of care. But a lot of times we talk about the hospitals, and yes, the hospitals are important, but there's other portions of home care. And I think COVID has really, really put it at home that we're all interconnected. It can't just be about one. It has to be about the nursing homes, private duty, home health, hospice. All of us, we're all one and we're all interconnected. And so that's really important for us to do. But the other portion of it too is that, I'm always looking for nurses, honestly, from hospitals, and I can't compete. Our rates would have to go up, astronomically to even compete. And that's because we're a single funding source. We only get paid when a nurse works, unlike hospitals that get paid for multiple different services. If you ever got a hospital bill, you know what I'm talking about. So with that being said, is they're able to then adjust their labor quicker than we want. And so that we're just always going to be chasing that in some ways. So that's why we want to make sure that we're reinvesting the save money and some things that we can do to, again, help keep private duty going for longer.
Thanks, Bill. One other theme that I want to pull out from the comments here is I just want to make sure there's clarification around if one were to choose to participate in this program, it doesn't mean that you have to now provide all the care yourself. So one thing I want to clarify is in the program, for example, in Colorado, a parent could be participating as a CNA in the program for a certain number of hours per week, but then the child may still have a nurse come at night, right? So it's as Kara and I have talked about it, this is about bringing together options to provide full staffing. So I just want to be clear about that as well. I don't know, Nanette, did you have any experience with that?
Yeah, definitely. There's seasons of life, right? So yeah. There's times when I was available to provide that care, and then there's times that I needed the help. I needed to work full time. There was no way that I could do it on my own. So the individual, the child, the young adult is authorized a set number of hours, and then different people can go ahead and work those hours, which is great.
Thanks.
Oh, I'm wondering where to shift now. I may just ask some quick ones. We've just, waterfall cascaded from one to the other. There's a great question here. Is there a role for private insurance in this? We've been talking strictly in Medicaid. What's the role of private insurance in home health, pediatric home health care and paid family caregiving?
And for this model, yeah, there is. Has there been any brave insurances yet that have done this? No. And I will have to say, sadly, I've been doing this for almost 20 years now. A lot of commercial insurance used to cover private duty medicine, and every year it's less and less and less. So I do hope that there are some maybe insurances that are on here today that may not consider this. But also, I think there's a great opportunity. One of the biggest private insurances is TRICARE. TRICARE has a very big benefit, and I think there's a lot of opportunity with TRICARE on the ECHO benefit. That's for those who have active military or active military to potentially have this as well. So, and one other comment just real quickly that I know people are talking about respite in that. I mean, this in some sense builds in respite, because if you can say how many, we don't limit how many people you get trained on your case. So with that being said, if you're getting the hours you're supposed to, then you can provide the hours that you want, and then the rest can be provided by others. So you're getting that grant. You're getting that time, you're getting that ability to go to the store, things like that. So it helps build that in the sense of some built-in investment and some off time.
Yeah, I saw early on there was a question about behavioral health services. So for those children that do not qualify for long-term care, what help is there available? Here in Arizona, we've really come a long way. So families can be connected to a behavioral health agency, and that case manager can get them help and resources. So respite is one of the things that's provided, a behavior coach, counseling, all these things can be provided even for those individuals that don't qualify for long-term care. So there is a lot of help. And then, we're really hoping that perhaps there's still a chance that flexibility that came with the pandemic for parents to be allowed to be caregivers, paid caregivers for their minor children, will be extended. But as of right now, it's supposed to end in 2024. So we'll see. And that's different than the licensed health aide position, because that's something that as long as the child has long-term care, the parent can be trained and can provide respite attendant care. Versus, they don't have to have those nursing hours authorized. So we'll see. We've definitely come a long way.
And in Colorado, they actually did expand this model to cover those with behaviorals and that's on the private duty nursing. They made that decision years ago. So that is something that states can always look into as well if they want to expand the population of this model as well. And there was a great question that just came about that we had to address about how does this affect your eligibility for Medicaid if you're a paid a parent caregiver? That's a great question. So either your state has a waiver program already in order for your child's income and your income is separated, so it doesn't affect that. Or there's then or state puts in regulations to make sure, like in Arizona, making sure that parents are and the child are not kicked off on Medicaid because of this. So that's how you address that situation.
There's a really great question in here too. I know we were talking earlier about supervision and training for families, and that's sort of built into the models that Team Select uses. You have to become certified as a CNA, or as has happened in the Arizona program, a licensed home health aide. There's a really great question though about what kind of training is provided. What if there's a family member, a parent or a guardian whose primary language is not English? Is there training existing in home health aides or for CNAs that is in languages other than English?
So yes, for example, here in Phoenix, where Nanette and I are from, Spanish obviously is a very large segment of the population of spoken English. And so, yes, we have materials. We also have personnel that we have that also speak Spanish fluently. So it just kind of depends on the area. I'm originally from St. Louis, so we had people there that spoke Aussie because there's a large Bosnian population there as well. So it just kind of depends on that, but yes. And then of course, we also have interpreter lines that are available 24/7 that are available in tons of different languages as well that we have to communicate to our clients and our caregivers.
Nanette, I saw you nodding too. Did you want to say anything on this, or do you have experience with?
Yes, so help and support can be provided in anybody's, their native language, and they can be trained. We as well, at Raising Special Kids, we've got staff that speak both Spanish and English, and then we use a language line for any other languages. So that should never be a hurdle.
I wanted to pull out one of the other more sort of in the weeds questions, and then go up to, there were some great questions around sort of, how do you form groups? Like, how do you organize people to organize in this? But if I can stay in the weeds for 1 second, there were some good questions about how's the pay, like take us back to the dollars and cents of this. Like, is this good and affordable for families? What I know you had that in some of your slides, Bill. I don't know if you want to weigh in, and then Nanette, if you can talk about how it's been in Arizona.
Yeah, again, we've come a long way. So
That
pay has increased. Go ahead, Bill.
Okay. That is the most important. That's one of the more important things. Not only making sure that we get reimbursed for the service, but we're doing so in order to pay parents a little bit of wage, and that means different things in different states. And so we have to take that in consideration. Where paying in the high teens, maybe here in Colorado sounds great, but if you talk about that in Massachusetts, they're going to look at you funny. So it just depends on the state. So we have to keep that in mind, and that's the one of the more important things, is that we want to make sure parents are getting paid a livable wage. Yes, they're there. Yes, these other family members are there, but they should not be taken advantage of. They need to be paid for their time, and also they need to be given opportunity, not only for extra training and education, but the opportunity like our parents in Colorado have, where they can move up if they want to go into nursing, and a lot do, nursing or therapy, things like that. And so it really helps to expose them into the healthcare industry, and really helps take them to the next step. But that is a very important thing. It just depends on the state. Now we're seeing a lot of states moving to a $15 an hour minimum requirement for care workers. So a year or two ago, I would say it's 15 or in the upper teens. Now it's even going higher than that. It just depends again on the state. And of course, if you're in a state with a very high standard of living, it could be even higher than that. But we talk with Medicaid in order to make sure that the reimbursement rate helps to do that, because we are business and we do have to make a little in order to stay in business. But with that being said, we also want to make sure our employees are always getting a livable wage and getting them the most we can give them.
I wanted to add to it, your experience comes into play as well. So an individual who's training, who possibly has experience and background, would possibly get paid more. And there's always the option for bonuses too, Yeah.
Thanks for adding that in. I just want to recognize we're almost at the top of the hour, and already this has been a really robust conversation. As we just put in the chat, the panelists stay on until 15 after, because there's so many questions. We want to make sure we can continue to answer them. We did want to recognize there's over 75 question and answers. I have to say that's the most of any webinar I've been in. So that really speaks to the volume of interest in this topic. We are going to take the list of questions consolidate them, and we'll be providing answers. So I'd really ask everyone to keep their eyes tuned for their emails following up from the foundation. We will be sending out both the recording of this as well as the slides and our eventually our responses to a lot of the questions. We will do our best. We probably won't be able to answer every state-based technical question, so I just want to call that out right now, but we'll certainly do our best. Kara and I, in envisioning this, really wanted to start a conversation nationally, and we hope, if nothing else, you've connected to people on this webinar, all the hundreds of people who are on, but also gotten a sense of the fact that people really care about this, and we hope it can be an option for others in other states. But we'll stay on for now and continue to work through questions. Kara, are there any else that come to mind for you now as a place to continue?
And if I could just, I'm sorry.
Yeah, go, Bill.
Go ahead, Bill.
Excuse me. I put my email in the chat as well. That way anyone can go ahead and reach out to me afterwards.
And I think it's in the slides as well too, right, Bill?
All of our things. I think all of our contact information is in the slides.
Correct.
Yeah.
Yep. But we'll make sure, Bill, that everyone gets it.
So, and sorry, I was choking it up there. Sorry. But my email's there. So if anyone wants to reach out to me afterwards and ask specific questions or anything like that, too, feel free. So.
Carolyn, I don't know if you had a place you wanted to go. I had kind of said, there was a few questions about, how do you structure, somebody had said, how do you figure out how to pull people together? And there is this larger caregiving discussion that includes, because our kids, grow up and they may need care on into adulthood. And then, there is a lot of discussion around the care for adults with disabilities and elderly. We've been trying to focus just in here about pediatrics and what happens with kids. But, how do you and your state's organizers, all as we discussed, there's so many layers and levers and policies, routes into paid family caregiving. I don't know, Bill, if you want to reflect on any experiences and coalitions in states, or Nanette, if you want to talk about the Arizona experience and being involved sort of in a coalition and who you would bring to the table, maybe.
Yeah, I think what we noticed in Arizona was that everybody was on the same page. Everybody saw that this was a problem. And then immediately hearing the family stories, that really tugs on the heartstrings, and hearing what was being proposed as solutions, everybody said, okay, this makes sense. And I think that's why it happened. And it, continues to be revised and improved, as time goes on.
That's so great to hear, because, and now right away, you're, saying everyone's on the same page. It's one global need, as families really do, or always do. I mean, really, I'm flip-flopping my words because I'm overwhelmed here at the end of the amazing webinar. But like, for us, the transitions are seamless. We think and see our kids all the way through the life course, and our loved ones that way as well. And it's nice to hear that that's the coalition. So anyone and everyone, I think, is really what you're saying. Bill, would you agree with that, or do you see it a different way, or have other experiences to share?
Well, I would, I would say too, yes, everybody was on the same page. I would say really, truly, here from the legislative side, it started with, there was an agency here called MGA Home Care. And they really helped lead the way to getting legislation passed. And then they brought on, which we really so appreciated, us and other agencies to get involved. We were like-minded to want to help. And again, I think this is one thing that COVID really helped do, because before COVID, a lot of us, especially PE agencies, they're kind of like, no, we don't want to talk to another agency. We don't want to talk to a competitor. And we've now all learned, hey, we're all in the same boat. We need to work together in order to help these families and help our industry. And how do we do that? And how do we? And so we work together. We share resources. We talk about these different things to do that. But the other thing too is, yes, home care agencies, associations are important, but families are so important.
Yep.
I'm telling this, if I got to bring in legislation, I know all of you who are on this call have done legislation too. They want to hear from the families. They want to hear what's going on. They really want to hear what's happening. and understand it, because they won't remember my bill, but they'll remember your story. They'll remember it day in, day out. And it's amazing how, when I speak to these legislators, they'll remember a family we met 5 years ago and the whole story. And so that is so important. So never discount that or discredit it in regards to saying that, oh, well, one person doesn't matter. Again, one mom started this in Colorado. One mom. I know her intention wasn't to start a revolutionary model. It was just to get care for her son, but that's what she did. And so that's the cool part about this, is you can make a change. It's not going to be overnight. It could take years. I have the New Jersey right now. We've been working on that for 5 years. Some states are quick and some states are not, but just keep at it. And look on your, talk with your home care associations, talk with the Academy of Pediatrics, talk with the family groups, things like that, and build those people together. Just, hey, I'm getting a call. You want to get on? We're going to talk about this. And then quickly you'll find allies and support.
Yeah,
I agree, Bill. I was going to say the same thing. As a pediatrician, I will make sure everyone is aware that there's American Academy of Pediatric state chapters in every state. And many of them, like Illinois, we have a Council of Children with Disabilities subchapter, which is pediatricians who have a particular interest, but we're not going to be able to do it alone. Families are really what make the difference in the stories. And I also think it's kind of a combination of the family stories, but then the people whose professional time can be allocated and used towards making it happen, right? Because you guys are you're trying to do the care. We have the professional time, and it's that match that can allow it, I think, to really happen, and allow us to make the case. So let us partner with you. There are many of us out there who want to, especially those of us who are, for example, at specialized hospitals where we have dedicated programs. That's another place you might be able to find some allies. It's not the only place, but it's certainly one of the places.
And one thing I'd like to add to this as well, I know there might be some Medicaid stakeholders on this call as well, is, us as agencies, I know a lot of times some people from Medicaid look at us and go, oh God, they're here, they want more money. No, not necessarily. What I want to do is help, and a lot of my fellow colleagues and a lot of other agencies want this. We know what's going on the ground, and we want to help make it better. And yes, sometimes that takes money, but sometimes that takes reallocating resources and looking at things differently. It may work, it may not work, but I think that's the one thing that I would say, if I could ask Medicaid to do anything in every state, is please engage with your agency, your home care agencies especially. Please engage with them, because not just getting on a call and telling me everything you're doing, but talking to us and actually engaging, having those quarterly conversations where we can share with you what our families are going through and what we see as the issue. Yes, there's staffing issues, but it's beyond that. There's other things that we can talk about to help resolve this and help you, not only better serve this population, but also save money.
One other, Kara, can I just say, I want to have one quick one, because I think
Yeah.
Tiffany has a question here about and I've seen a couple times about whether there's a comprehensive list.
Yeah.
So we'll include in our resources a link to the national NASHP, the National State Health Program. Oh my gosh, I'm messing up the acronym. Do you have it, Kara? I can't think of it at the moment.
National Association of State Health Policies.
Thank you. I knew Kara would know it. So they, a couple of years ago, did a summary of paid family caregiving programs, and they have a pretty detailed table looking at some of the Medicaid specificities. But the reality is I believe it was published pre-COVID, and so it's a little out of date. I think it's a helpful document for people to see, to get a little bit of sense beyond our slides of the flavor of what you need to kind of look at to be able to really start to dig at where your state might be. But that's at least a starting point. And then hopefully it looks like our chat here is a lot of people connecting over what might be going on in your state. So those are some resources to think about how you could understand what are going on in different states. Go ahead, Kara. I just want to make sure I pointed out that resource was going to be shared.
Yeah, well, I was actually gonna go that way too, because Allison shared a great question that was, asking, like, wanting to know from Bill and Annette, like, are there any particular infographics that you guys know that have been helpful with legislators? I saw there was a lot of really great talk in the chat too about, like, oh, we should have invited our legislators to this, but guess what? There's a recording, so it can be shared. And that's what people were saying, like, can we share this recording with legislators? And that's really one idea. And I think it speaks to the creativity that just happened in this hour. Do you guys have ideas of things that worked really well with legislators? Other than, Bill, you were saying really the stories and personalizing, humanizing, because that's what this is really all about. It is a workforce issue, but it's about a child and a family and life, right?
So once you talk to a legislator and you tell them that this is a child that needs to be fixed, how it needs to be fixed, because again, usually we hear from people like myself, they're asking for rating groups, they're asking for money. And that's important as well. But when it comes to this, once that's done, usually what I do is that presentation that I give, those last 4 slides, I have a decision tree that we also included in the information that'll be after this webinar. I usually go over that with the legislator to explain to them where this model will fit and why we need legislation, so they can really understand what we're talking about, because they'll speak to many different stakeholders from different departments who are going to have different opinions. And so I try to make them as informed as possible and have that information. So that way, if somebody comes back and says, no, it needs to be over here, the next thing, no, it doesn't, because of this rule or this rule or that. So that's one of the biggest things, is usually in that decision tree. I find it's very helpful to talk about those different things. And I came up with that just over the course of years doing this and learning sometimes the hard way. And so those are the things that I have learned of how it can fit and how it can't fit. Because that was the question a lot of people ask me, well, can you give me something that can show me, some kind of resource or cheat sheet? And that's kind of my cheat sheet that we utilize to show how that model could essentially work in your state.
Yeah, I would add, for parents looking for where do we start? So contact your local agency, so your local parent training and information center. You can find that, online, you can Google it, or your Family Voices chapter, because they're going to have, a real good idea as to what's going on in the state, what's available, where they're at. And often that's how parents just get to learn. They train to be a volunteer for the agency, and then they learn to find their voice and how to share their story. And, it's really great to be able to give back that way.
Thanks, Nanette. I wonder, let's shift. We only have like a couple more minutes left in our extra, oral, virtual, live, whatever recording, and then we'll get to the business of writing answers to the questions. But there's several questions sort of around, which I would kind of group in, like, really, what are the benefits? I can't remember, but Bill, I think it was in one of your slides of, like, what are the long-term? Yeah, it was one that we stopped on for 2 seconds, right? And we'll have to go back to. But, there are some questions that came up about, how does this affect continuity of care? And I know you've mentioned before that one of the big concerns in Colorado is, well, families will, be paid as family caregivers and then not want to stop being paid as family caregivers. And, perhaps there's an over medicalization of the child, or, issues of that. Can you really talk to, what are some of the benefits in terms of the care of the child and the health of the child that have been shown by these models in all the places you've worked, Bill, and thus far in Arizona and Annette?
Sure. I'd say the biggest one is the hospitalization drop. Typically in most states you see anywhere, the hospitalizations are for private duty nursing agencies on a monthly basis are 18 and 21%. It seems like we're doing pretty well between 8 and 12. In this model in Colorado, it was anywhere, as you saw, 0.3 to 0.6%, which is huge. And so that was one of the biggest benefits, because obviously nobody wants to be in the hospital unless you really have to be in the hospital. But also, paying parents that are providing this care, also giving them hours. Just to be honest, mom is usually the one that's sandwiched with this responsibility in the home. And with that being said, is now you're giving her options on who she can bring in to help her, being that if that's maybe her sister, her mother, the neighborly grandmother down the street, you know, whoever that is, but you're giving them options to help that they trust. So when they go to Costco, they're not worried about, you know, rushing home. They're worried about getting their groceries done, you know. So those things also, you know, in some instances, well, there's a lot of families, unfortunately, the marriages for medically deprived children, the divorce rate's 80%. And so there's a lot of parents become single parents, get on government assistance. This helps get them off government assistance. And so that's also helps as well. The other thing too, I think is really important about this, a lot of people kind of forget about it. I have to remind the state is that, you know, as an agency, usually on a private duty, I'm usually dealing with 5% of my census, 90% of the time. So I'm dealing with like complaints and issues and things because there's not enough staff, or there are staff, there's issues out there, things like that. A lot of that stuff goes away when under this model. So you're not dealing with that because everyone knows each other, you have consistency of care. And so there's a lot less back office for not only a home care agency, because you don't have to have as many recruiters and things like that, but for the case managers at the state, they are dealing with the same issues we're dealing with, but now those go away. So now they're able to go out to the home, they're able to go out and do the case management that they want to do. You know, there's a big, as many of you know, in every state, states are clamoring for people, but especially for case managers. And so this allows them to get back and see what they'll tell you, their babies. They get out and you need to see their babies. And that's what they want to do. So it also, there's more fulfillment for those case managers because they're able to, instead of taking complaints all the time, they're able to actually manage their cases.
Thanks so
Nanette,
much.
do you have,
Oh, yeah.
oh, you want to cut
Oh,
it? Yeah.
did you have anything to
I
add?
just want to see if Nanette has thoughts.
Beautifully put, Bill. And I can share with you too, we've had a lot of dads. So a lot of single dads that have lost their job because of the amount of time that they had to spend with their child, whether they were hospitalized or just at home. But yeah, just the basic need to have somebody who's going to show up. You know, we love our nurses, but the reality is that sometimes they get sick and they call out and they can't come. And, you know, this, obviously we don't have to worry about that. So if it's the parent, the guardian providing the care, we don't have to worry about, you know, our provider calling out. But yeah, it's, I just think it's a wonderful program. And I really hope that nationwide that it really gets embraced and we move forward.
Yeah, continuity is really key to good care, good health outcomes, and being a kiddo, right?
Right.
Carolyn, you wanted to say, I think, wrap up, and I just wanted to say thank you to everyone too. Thank you to our speakers, to my partner in crime, Carolyn Foster, and to Lucille Packard Foundation. This has been really wonderful, and thank you for allowing us to have the opportunity to have this national conversation. Carolyn, I'll give you the last word.
Yeah, I mean, I want to make sure that everyone knows that we support all of you. We want to work with all of you. I saw a lot of calls for a national approach. I think this is a wonderful start to a conversation, and we hope that it's connecting everyone. And just a reminder that this is really thought of as one policy solution among many. So we aren't going to abandon all the other things that need to happen to improve care for children. It's really about working together on different options. So thanks everyone for coming, and we look forward to this continued conversation.